we have an audience, and I believe we're broadcasting. So I'd like to quickly say welcome to everyone who is joining us today from hopefully the comforts of your couch, but wherever you are, we're glad you can join us. Today's a special edition of our live webinar series. Today, we are focusing on the management of cardiovascular, gastrointestinal, and hormonal manifestations of Pheos. I am Mark Pilkington. I will shortly introduce Dr. Jimenez, who is also on. I'm a board member of the Pheo Association. I am blessed to be able to be a part of this group as back in 2018, I discovered that I had a spontaneous paraganglioma, posterior mediastinal. It was about the size of my fist, abutted to my aortic arch. I sought care after I discovered what it was down at MD Anderson, where I was blessed and fortunate to meet Dr. Jimenez, who is my primary care physician in terms of ongoing care for my, again, spontaneous paraganglioma. And I hope I never have to go through that again, but I believe I'm one of the unique ones where I have no unique hereditary ties to my condition. Again, it was sporadic. So without that, I wouldn't be here today and speaking with you all and Dr. Jimenez. So I'm here with Dr. Jimenez again, who I'll introduce in a moment. But first, I wanted to at least acknowledge why we're here today, and that's because of the Pheo Alliance, who is presenting this today, whose mission is to empower patients with pheochromocytomas or paragangliomas, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. Special thanks as well to Progenics for making this webinar series possible through an educational grant. So thank you. I do have to say real quick before moving too much forward here that our first ever organized Pheo Awareness Week will be the week of August 23rd through the 29th. Our motto for this week is Pheo Fearless, and that is with a catchy PH, fearless. So Pheo Fearless. You can find out how to participate on our website at pheopara.org. We do have a couple more webinars occurring over the next month as well. Our first one coming up after today is a Pheo Research Update webinar. That will be on August 10th with Dr. Clifton Bly. Our next Pheo webinar will be covering the Pheo and gastrointestinal stromal tumors, or GIST. That webinar will be in exactly 1 month from now on August 29th with Dr. Siklik. You can sign up for both of those webinars by going to pheopara.org. You can also sign up for our e-news and follow us on social media by looking for Pheopara, at Pheopara on Twitter or Pheo_Para on Facebook. So today, our agenda will be for our meeting where Dr. Jimenez will present for roughly 25 minutes. After his 25-minute presentation, we will open for Q&As. A lot of the questions were submitted prior, so we do have plenty of questions already here. If you have any questions throughout the webinar today, please feel free to submit them through the chat on your Zoom meeting window. So many of the same people ask variations of the same questions, so please listen carefully if you hear something similar. Questions that are less case-specific are appreciated, as the ones that are case-specific are very difficult to address. I'd also like to say that the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctors and medical team, because they don't have in-depth knowledge of your specific medical history and current situation. So please keep that in mind. Without any further ado, I would like to introduce now my physician, Dr. Camilo Jimenez. Glad you're here today. Dr. Jimenez is a professor of endocrine neoplasia and hormonal disorders at the MD Anderson Cancer Center in Houston, Texas. He's performed extensive clinical research in the field of endocrine cancer with a particular interest in pheochromocytomas and paragangliomas. Dr. Jimenez was one of the first clinicians to describe the use of tyrosine kinase inhibitors, if I said that wrong, you can laugh, in patients affected with sporadic and hereditary malignant Pheos and paras. His observations led to the development of prospective multi-institutional and international clinical trials. Dr. Jimenez also characterized inherent complications related to excessive hormonal secretions and tumor burden distinctive of this disease. Dr. Jimenez, welcome. Glad you could join us today. And I'd like, of course, to ask you now to share your screen and begin the presentation. Thank you.
Really, thank you very much for this very nice invitation. Thank you to everybody for being here today. And let's share my screen if I can do it. It says that the host has disabled the participant screen sharing.
And we will get that fixed right away. I believe Stephanie sees that.
Thank you. Okay.
There we go.
Now I see it. I just click on this, I think. Then I share and make it bigger. I'm going to make it like this. Really, thank you very much for this invitation. So what we are going to discuss today is just the management of the hormonal manifestations of pheochromocytoma and paraganglioma. So the outline for this presentation will have a brief introduction, where we are going to review the anatomical definitions of pheochromocytoma and paraganglioma, why they produce hormones, and why the clinical manifestations of the tumors are frequently hormonally driven. In addition, we are going to talk, and this is the main focus of the conference, on the treatment of hypertension, as well as the prevention of cardiovascular complications. And at the end, I want to discuss with you something that is frequently missed from clinical practice, which is the management of gastrointestinal problems in pheochromocytomas and paragangliomas. My goal is in reality to give you some tools that to you as individuals or caregivers of patients who have had pheochromocytomas and paragangliomas could be useful in your regular lives to help them control the manifestations of the disease and, of course, to prevent complications associated with them. So let's talk a little bit about what a pheochromocytoma and what a paraganglioma are. So these are tumors that are coming from a very important structure that we call the paraganglia. The paraganglia is what we call a group of neuroendocrine cells that during the embryonic life are going to migrate to give origin to the different components of the autonomic nervous system ganglia. So I know that the terminology here may sound a little bit confusing at this time, but I'm going to explain everything clear to you. So what we are talking about here is really the autonomic nervous system ganglia. What is the autonomic nervous system ganglia? The important part of the definition is the first word, autonomic. What autonomic means is independent. And why we call it independent? Because it is independent or autonomic of the consciousness. It is something that we cannot control with our mind. And it is important to recognize it because the pheochromocytomas and the paragangliomas will develop in the autonomic nervous system. So what is the autonomic nervous system? So we are going to make an analogy to a subway or to the metro or to the train. And we are going to assume that we have stations where the subways will arrive. They leave passengers and then those passengers move into other metros or subways until they finally arrive to their destination. So we are going to use that analogy to really define for you what is the autonomic nervous system. So when you look at the graphic that is located in the right side of this slide, you see in the right side an individual. That individual has the brain in the upper part, of course, and the spinal cord that comes in the posterior part of his body or her body. And from those areas, you will see several tracts, several railroads. We are going to call them the railroads that are supposed to take those passengers that are electrical messages into the final destination. And the final destination here is an organ that we are not able to control with our consciousness. Those organs are very important. Those organs are the ones that help us to be alive. They are the ones that help us to understand the environment, to connect, to respond to stress, to survive whenever the conditions around us are aggressive. And of course, we cannot control those organs. They have to do it on their own, and that's what the autonomic nervous system does. So the final destination of those electrical messages are organs such as the heart, the lungs, the stomach, the liver, the gastrointestinal tract, including the small intestine and the colon, the kidneys, the bladder, as well as many other visceral organs. And of course, they have to work independently. We cannot tell the heart, please stop working or work faster. No, it will do it depending on how our system sense that we have to be in a particular situation. We cannot tell the lungs, please stop breathing. No, they will have to do it because they have to preserve the concentration of oxygen that we have in the blood. We cannot tell the liver how to digest food. We cannot tell the stomach how to work. We cannot tell the kidneys how to clean the blood. So this is why we call this system the autonomic nervous system. And the autonomic nervous system, to make it relatively simple, has an initial station. The initial station is either the brain or the spinal cord, where those electrical messages are sent to those in between quotations, railroads. They will arrive to a second station that is midway in between the brain and the spinal cord and the visceral organs. That second station is what we call the autonomic nervous system ganglia. And then from there, the passenger, the electrical message is transferred to another train, another electrical messenger that will take the message to the organs, which are the heart, the lungs, the kidneys, and the others that we previously discussed. What is important here, that in those stations that are located midway, what we call the autonomic nervous system ganglia, is where the pheochromocytomas and where the paragangliomas develop. So these are tumors of the autonomic nervous system ganglia, and because they are part of the connection that we have with different organs, visceral organs, whenever they become abnormally active, whenever they produce hormones, yes, those organs may be altered in the way they work. And that's why people with pheochromocytomas and paragangliomas may have symptoms that we'll describe later, such as palpitations, such as throbbing headaches, as well as many cardiovascular, gastrointestinal, and other endocrine complications. So let's talk now about the main hormone that is used in that particular midway station, the autonomic nervous system ganglia, hormone that because of the origin, the paragangliomas and the pheochromocytomas may produce. That hormone is noradrenaline. Noradrenaline is a catecholamine. Under normal conditions is going to help us to facilitate the electrical transmission in the autonomic nervous system. But whenever you develop a paraganglioma or whenever you develop a pheochromocytoma, the noradrenaline may produce in excess. And this is a hormone that under normal conditions is important to help us to fight or to escape whenever we are under stress. Well, when you have a tumor like a pheochromocytoma or a paraganglioma, there is no regulation of it. The tumor may simply produce whenever it wants noradrenaline or adrenaline in the case of a pheochromocytoma, and the production of noradrenaline and or adrenaline, which are the catecholamines, are going to make us feel as someone who is under stress. Again, that's the reason why, for instance, we may see symptoms like palpitations and others. So what are pheochromocytomas? The name pheochromocytomas, you know, is given exclusively to those tumors that are coming from the adrenal gland. These are tumors that are coming from the central part of the adrenal gland that we call the adrenal medulla, and because of that origin, they may produce catecholamines such as adrenaline and or noradrenaline. And whenever they are produced in excess, yes, of course, they may predispose to cardiovascular disease as well as other endocrine complications. And I'm going to show you an example of what a pheochromocytoma or what pheochromocytomas may be. This is a very interesting slide. I really like it because it's quite colorful. This is coming from one of our patients at MD Anderson. This is what we call an angiogram with tomographic reconstruction. We call it an angiogram because it has information, anatomically speaking, on the vessels of this particular individual. So when you follow the arrow, you will see here the aorta. This is the abdominal cavity. And here you have several organs that are normal. Here you have one kidney. This is the right side of the individual. This is the left kidney. Here you have the spleen. And in the upper part, you can see the heart. And yes, you see the skeletal tissue. For instance, you see the spine. You see the ribs in the upper part, the chest wall. And in the lower part, you will see the pelvic area. Now, in green, there are two different tumors. Those tumors are pheochromocytomas, and I just want to tell you the graphic to me is important because it's showing you the anatomical characteristics of these tumors in relation with other organs. So yes, they are coming from the adrenal glands. They are, because of that, on top of the kidneys. So there is a tumor that is larger located on top of the left kidney, and another one, which is smaller, located on top of the right kidney. This is an individual who had bilateral pheochromocytomas, and something that likely many of you know by now. Whenever you have evidence of more than one pheochromocytoma or of more than one paraganglioma, you have to remember that for most part, those patients have a familiar or hereditary predisposition for disease. In other words, when you have multifocality, multiple tumors, yes, you may have a hereditary predisposition for disease, and we have to look for that in order to understand better what you have, and of course, to characterize better your family. But this is the image that we can have in a very nice, very colorful way of what a pheochromocytoma may be. Now let's talk about the word paraganglioma. The term paraganglioma is given to those tumors that are coming from those autonomic nervous system ganglia that we described at the beginning, but which are located outside the adrenal gland. Again, pheochromocytoma is inside the adrenal gland. Paragangliomas is outside the adrenal gland. And the paragangliomas could be classified depending on their location in what we call parasympathetic as well as sympathetic paragangliomas. The definition is important because the way they behave is different. The way they, hormonally speaking, are is also different. So for instance, the parasympathetic paragangliomas are coming from the autonomic nervous system ganglia that are located in the head and neck. And they have names such as the ones of chemodectomas, carotid body tumors, glomus jugulare tumors, and many others. These are tumors that for most part are not hormonally active, and therefore they do not predispose to cardiovascular, gastrointestinal, or other endocrine complications. The sympathetic paragangliomas, different from the parasympathetic, are usually hormonally active, and they are coming from other parts in our bodies. They are usually in lower locations at the head and neck. They are coming from the chest, from the abdomen, from the pelvis, and different from the parasympathetic paragangliomas. Yes, they may produce catecholamines, and the main catecholamine that they produce is noradrenaline. And because of that excessive production, yes, patients may have cardiovascular and gastrointestinal complications. To give you an example of what a paraganglioma is, this is again an angiogram with the tomographic reconstruction. What you have here is in the upper part, the aorta, and you see that the aorta divides into different vessels. These are the iliac arteries. They are going to the right and the left lower extremities. They are the main sources of blood flow for the lower extremities. In blue, you have the veins that are companions of the arteries in this area. Then you have here the abdominal cavity. You see here the pelvic area. This is the pelvic bone. Here you see the hip. This is the right hip. And here you can have the femoral head, which is important for the rotation of the hip. And in this part, you have the spine. And then in the middle, you have a tumor that is green. This tumor is located in the posterior part of the abdominal and pelvic cavities. It is in reality in between the abdominal and pelvic cavities, in front of the spine, in between the vessels, and this is what we call a paraganglioma. And because of the location, this is designated as a soccer candle paraganglioma that likely many of you have heard of whenever you read about paragangliomas. So this is one of the tumors that we may see in clinical practice. And of course, several of these paragangliomas may happen in the abdomen, may happen in the chest, may happen in the pelvis. An important aspect is that the autonomic nervous system ganglia does not have ganglia located in the upper and lower extremities. Therefore, you are not going to see primary tumors located in the upper or lower extremities. Yes, you may see paragangliomas that have spread into the upper or lower extremities, but those are not the primary tumors. Those are the metastases of some of those tumors. So the clinical manifestations of paragangliomas or pheochromocytomas are in general dominated by the hormonal activity. If you look at the graphics that we showed before, these are tumors that are posterior for most part. They are located in the posterior part of the abdomen, in the posterior part of the pelvis, in the posterior part of the chest. So these are tumors that are difficult to palpate during the physical exam. And for most part, we are not going to feel them. However, they are many times telling us that they are present. And the way they do it is because they may predispose to that excessive hormonal activity, and that hormonal activity will imply interactions with multiple receptors for those hormones that are located in those organs that are controlled by the autonomic nervous system, including again the heart, the lungs, the kidneys, and many others. And because of that, patients may have more than 100 different manifestations associated with catecholamine excess. The most common ones are the ones listed in this table, and they include the headaches, the palpitations, and the sweats, which together may appear in about 50 to 90% of patients. They may not be present in everybody, but whenever you have throbbing headaches, whenever you have palpitations, when your heart is pounding faster, whenever you have sweats, which is what we call diaphoresis, yes, many of these patients may have a pheochromocytoma or a sympathetic paraganglioma. Other symptoms are listed there. They include the pallor, the nausea, sometimes vomiting, constipation that we'll talk about later. Yes, some patients may have weight loss because of the stress that they are facing. They may have fatigue. They may feel very anxious. They may even have panic attacks. And one of the most common manifestations that we see, and perhaps one of the most overwhelming ones from the endocrine perspective, is the presence of hypertension or high blood pressure. The high blood pressure in patients with pheochromocytomas and sympathetic paragangliomas is a high blood pressure that could be present the whole time. That's what we call a sustained hypertension. It may happen in spikes. There are times that the patient feels just normal. There are times that the patient does not feel well and the blood pressure is high. That's what we call paroxysmal hypertension. And believe it or not, in some patients with pheochromocytomas or sympathetic paragangliomas, instead of being hypertensive, they may experience what we call orthostatic hypotension. What is that? The blood pressure goes down whenever we stand up, whenever we get up, for instance, from the chair, from the bed, from places that we were quite comfortable. And when we do it fastly, yes, sometimes the blood pressure goes down because the blood goes to the lower extremities very fast. And yes, we may see that sometimes as a clinical manifestation in patients with pheochromocytomas or sympathetic paragangliomas. So what is the important part from this slide? The important from this slide is to recognize that pheochromocytomas and sympathetic paragangliomas, because of the hormonal activity, may give you many different symptoms. And whenever those symptoms are present, yes, patients, providers, caregivers may think about the possibility of a pheochromocytoma or a sympathetic paraganglioma as the tumor that is behind or the condition that is behind the presence of any particular manifestation like this. So let's talk now about the complications that we have because of the excessive hormonal activity coming from the pheochromocytomas and paragangliomas. And to illustrate this, I'm going to show you one of our patients. As MD Anderson, this is a real individual, and I'm going to tell you what happened with him when he appeared for the first time with a pheochromocytoma in our clinic. This individual at that particular time was very young. He was only 18 years of age. This is someone who was feeling really fine for several years without any problem. But more recently, the patient had back pain, he had throbbing headaches, he had sweats, he had palpitations. He arrived to the emergency room. At the emergency room, they checked on his blood pressure. The blood pressure was 137/65. And I can tell you that it's a normal blood pressure. So things were really fine. However, there were symptoms that were suggestive of a pheochromocytoma or paraganglioma, symptoms that to the clinician suggest that the patient may have an increased hormonal activity. And because the patient was in the emergency room, the clinician ordered a CT scan of the abdomen looking for a potential pheochromocytoma or a paraganglioma. So this is the CT scan of the abdomen. I'm going to show you what is normal here. What is normal is what you see in this area. This is the liver. This is the biggest gland that we have in our body. Here we have the stomach. Then here we have the spleen. Here we have a kidney. This is anterior and this is posterior. So this is the back of the patient, and here you see the spine. This is one of the vertebral bodies. What it is abnormal is what you see in the right side of the abdomen. In the posterior part of it is this tumor. This is a 3.1 centimeter tumor that is located in the right adrenal gland. What kind of tumor is that? Well, the clinician who saw the patient in the emergency room ordered biochemical testing, and the norepinephrines of this patient were elevated almost 6 times the upper limits of normality. Given the fact that the patient had symptoms such as throbbing headaches, sweats, and palpitations, together with these biochemical abnormalities and the radiographic findings that you see here, the clinician made the diagnosis of a pheochromocytoma. And as you likely know, everybody who has a pheochromocytoma or a sympathetic paraganglioma or a paraganglioma in general, whether it's sympathetic or parasympathetic, yes, genetic counseling is indicated. He didn't have it in the emergency room, he had it later, but the genetic counseling was very interesting because he was associated, or in his case, there was a recognition of a von Hippel-Lindau disease mutation that, as you may know, may predispose later to kidney cancer, pancreatic neuroendocrine tumors, and other complications. And thanks to this, the patient is now under regular screening for von Hippel-Lindau disease. And I can tell you, the only manifestation the patient has had so far is just the pheochromocytoma, and this patient has been patient of mine since 2009. So far, he's been doing really, really well. But the important part is that he was having symptoms. So how are we going to control the symptoms that the patient has? Well, we have to get rid of this tumor to suppress the production of catecholamines. So we have to do surgery for that patient. But we have to remember that surgery could be a risky procedure for patients who have pheochromocytomas or paragangliomas that are hormonally active. And why is risky? It could be risky because of several aspects associated with the procedure per se. So for instance, these patients will require a mechanical intubation, and yes, the intubation may predispose to a catecholamine crisis because it's stressful. Many times, the surgeon has to do a laparoscopic procedure, which is very nice because the incisions are very small. But in order to create the space to remove the tumor, the surgeon must place air inside the abdominal or pelvic cavity to remove the tumor. That insufflation, which is what we call the peritoneal insufflation, may compress the tumor and may release catecholamines. In addition, in order to remove the tumor, yes, the surgeon is going to touch the tumor, and of course, the pressure that is causing the tumor may release the catecholamines. Other aspects related to surgery that may predispose to a catecholamine-related problem at that particular time are given by medications, such as the opiates that we use to control the pain of the patient during surgery, medications that relax the muscles, which we call the neuromuscular blockers, medications that are able to release the anxiety that the patient has, as well as medications such as the antiemetics, medications that we use to prevent nausea or to control nausea, such as metoclopramide, which is a classical one, and other drugs such as the sympathicomimetic medications or the vagolytics, which are drugs that are going to help us to preserve the blood pressure during surgery, as well as to decrease the production of secretions while the patient is intubated and unconscious. The important part to remember here is that whoever has a pheochromocytoma or a sympathetic paragangliomas, a patient, yes, during the time of surgery, may be prone to complications because of all these different aspects related to surgery. Those complications, which are complications that may also happen without the time or not related to the time of surgery. There are patients in whom the pheochromocytomas and the sympathetic paragangliomas are very active. They simply produce hormones. They may also predispose to complications that are not related to surgery, are the ones that we have listed in this table. So these are the complications we have, and they are due to aspects related to activation abnormally of the autonomic nervous system. So in the left side, you are going to see the organs that are affected, and at the end of the right side, you will see the potential complications. So when the catecholamines are produced in excess, they may interact with what we call the alpha-1 receptors. And what we are going to discuss here are the complications mediated by alpha-1 receptors. Those complications are coming from the interactions of the catecholamine with organs such as the coronary arteries, the brain, the lungs, the abdominal viscera, and the kidney. And what are those complications? Well, when they interact and cause toxicity on the coronary arteries that are located in the heart, they may predispose to angina or heart attacks. When they have or they cause toxicity on the brain, they may predispose to strokes. When they work in the lungs, they may cause congestion in the lungs, which is what in medicine we call pulmonary edema. In the case of the intestine, they may contract the vessels, they may decrease the amount of blood flow that arrives to the intestine or to the colon, and that may predispose to intestinal ischemia, which is equivalent to a heart attack, but in the intestine or in the colon. And when they work in the kidneys, they may prevent the arrival of the blood flow that the kidney needs, and because of that, the kidney may not work well, and the patient may have renal failure. And everything is mediated by the alpha-1 receptors of the autonomic nervous system. There are other receptors that we call the beta-1 receptors. They are mainly located in the heart. They are responsible for the electrical activity of the heart and for the contraction of the heart. And whenever they are activated by the catecholamines, that excessive activation may induce in the heart an increased oxygen consumption, and that oxygen consumption is given by the fact that it contracts faster, it is working at a higher speed, and because of that, patients may have angina or chest pain, heart attacks, arrhythmias, and other complications. So these are important complications related to the expression of catecholamines by pheochromocytomas and paragangliomas. So how do we prevent or control those? Well, there are several medications that we can use in order to do it. And we have learned from clinical experience that yes, they may have an impact. And those medications are, for instance, what we call the alpha and the beta blockers. And we are going to talk a little bit about those. The experience with the alpha blockers that is telling us that really they are able to prevent complications is, for instance, coming from this study that was published in 1999. It is just a collection of clinical information. It's the clinical experience of a group of surgeons who have worked on pheochromocytomas and paragangliomas for decades. And what it is very interesting here is that the use of medications that we call alpha blockers was associated with a very low risk of complications at the time of surgery whenever they were used, when compared with patients who had pheochromocytomas and paragangliomas who did not have treatment with alpha blockers. To give you an idea, those patients who were not treated with alpha blockers before surgery, the rate of complications was almost 70%. But for those patients who were treated with alpha blockers before surgery, the rate of complications was only 3%. What are the alpha blockers? The alpha blockers are medications that will work on the alpha receptors, as we discussed. They are going to prevent the interaction of noradrenaline and adrenaline with the alpha receptor, and by doing so, they may prevent the cardiovascular toxicity. There are two different groups of agents. They are separated here by the red line. In the upper part, you will have what we call a non-selective, non-competitive alpha blocker. The one here is phenoxybenzaimine. Likely many of you are familiar with it. It is a fantastic medication. It's a drug that we classically use for the treatment of patients with pheochromocytomas and paragangliomas. It lowers the blood pressure very well. Yes, sometimes we have to titrate the dose up. Everybody is different. There are some people who may need a minimal dose of phenoxybenz. I mean, there are people who may need a very high dose, up to the point that the dosage of phenoxybenz, may go from 10 milligrams daily up to 140 milligrams daily. And it's in general a very safe medication that of course may cause hypotension because that's what we want to get. But it is a drug that could be quite effective in preventing cardiovascular disease for patients with pheochromocytomas and paragangliomas. Now, if you ask me, do I use it frequently in clinical practice? I'm going to tell you for most part I don't. And it is not because I have medical concerns. For reasons that are not clear to me, phenoxybenzamine in the United States is a very expensive drug. I don't understand why a drug that has more than 100 years since the time that was discovered cost in between $1,500 and $3,000 per prescription. No many patients are able to afford it. No many health insurances will provide it. There are some that will do it, and if they provide it, that's fantastic. We can use it in clinical practice, but that's one of the limitations that I have whenever I treat patients with pheochromocytomas and paragangliomas, because it is in reality very expensive. Saying that, it's an excellent medication. So the medications that I mainly use are the ones that are located beneath the red line. These are alpha blockers. They are called, different from phenoxybenzamine, competitive. And what is the meaning of competitive when compared with the non-competitive ones? To make it practical for you, the non-competitive ones last for a long time. For instance, phenoxybenzamine lasts for 10 days. The activity of that drug lasts for 10 days. But in the case of prazosin, terazosin, or doxazosin, their half-life is in reality very short, and that has to do with the fact that they are competitive. Now, perhaps you are not familiar with the scientific names of these drugs, which are the ones that are listed here, but I'm going to tell you about the brand names. Prazosin is Minipress, terazosin is Hytrin, and doxazosin is Cardura. And in clinical practice, the ones that I prefer to use are the last two, terazosin and doxazosin. And I prefer these two when compared with prazosin, simply because prazosin lasts for a very short period of time. The half-life is only 3 hours. The other medications last for longer. They are more stable. Therefore, they are able to help us to obtain a more steady control of the high blood pressure that the patient may have. And when compared with phenoxybenzamine, they are cheaper. So these are drugs that are covered by the insurance, or if you have to pay for them, usually the price that you have to pay for per prescription is in between $4 and $20. So they are much more cheaper than whatever we have with phenoxybenzamine in clinical practice. But again, these drugs are effective. Prazosin to me is a short-term medication. I don't use it very often. Phenoxy is excellent. The problem is the price. Terazosin and doxazosin are currently my favorite because they are quite effective and the price is quite acceptable. The other drugs that we have to use are the beta blockers. So the alpha blockers, as we discussed before, they are going to protect organs such as the coronary arteries, the intestine, the kidneys, the eyes, the lungs, but they are not going to protect the heart. So we have to use the beta blockers to protect the heart. And there are several names here. They include medications such as metoprolol or atenolol, propranolol, laveralol, and carvedilol. Just to let you know, laveralol and carvedilol are in reality mixed medications. They have or they cause alpha and beta blockage. But for the purpose of pheochromocytoma paraganglioma, they are beta blockers. That's how we do it. And they are always used after the alpha blocker. And yes, there are others. I'm just going to mention them to you. Sometimes the blood pressure is difficult to control, but we have to keep in mind that we can use them, and they include the calcium channel blockers, the angiotensin conversion enzyme inhibitors, and the angiotensin receptor blockers. So we have many options. And what you have to remember is that the treatment of blood pressure and prevention of cardiovascular complications is something that is individualized. Everybody is different, and we treat every patient in a different manner. So sometimes we have to use more medications than when we use in another individual.
Dr.
Another drug?
I'm sorry, if I can just interrupt real quick. We have roughly 2 to 3 more minutes before we can get to questions. If I just wanted to give you a quick
fine, and I think I'm going to finish soon.
Great.
So this is a drug that is recommended sometimes, but I can tell you metyrosine is quite difficult to get and it's very expensive and it has some toxicity. And in general, if you have good communication with the patient, you may be able to control the blood pressure in a matter of 7 days. The way we do it at MD Anderson is patients provide us with blood pressure and heart rate control numbers every day, and we adjust the medications periodically, and patients are usually controlled very fast in clinical practice. Another aspect to remember, although they are hypertensive, they are usually hypovolemic. They don't have a lot of water, so there is no need to restrict the amount of salt in your diet. The diet could have a normal salt content. So that's an important part. And finally, and briefly, I'm just going to tell you about one complication that many times people don't know about, and it's important, which is constipation. Constipation in patients with pheochromocytomas and paragangliomas could be quite aggressive. You may see it in this graphic, someone who has a very distended abdomen with a colon full of stools. And the patient is very uncomfortable, the patient has a lot of abdominal pain, and the patient is even having fever. And this is something that many times people do not know how to treat. The important part about constipation is that it happens in some patients with pheochromocytomas. It starts like a mild problem. People don't pay attention to it, and then it becomes severe. And that problem may predispose to bleeding in the gastrointestinal tract, perforation, obstruction, infection, and even malnourishment. And people think that this is a problem that could be treated with alpha and beta blockers, and the answer is no. This is something that is treated with diet, with liquids, especially at the beginning, and more important, is preventable. So just remember that there are some principles, just I'm going to mention them briefly, and later on we may talk about if you want, but the diet of someone who has pheochromocytoma and paraganglioma needs to have a lot of fiber, a lot of water, and yes, it is important to drink warm beverages such as coffee or tea, because they are going to induce the motility of the gastrointestinal tract, and they can help you to prevent the constipation. And there are other treatments that we may need to do, especially for severe forms, but I'm not going to discuss that right now, although I can send you that information later in case you need it or in case you want it. So I'm going to stop here. I know that it took a little bit of longer of time, and I apologize for that, but I suppose you may have some questions in regard to cardiovascular and gastrointestinal problems. Let's see what you'd like to know more.
You know, Dr. Jimenez, I'll say thank you very much for that presentation. Even sitting here today, I've learned quite a bit, more than I had even realized before. So thank you.
Thank you.
You know, one of the first questions here that I see that we'd like to ask and get some answer from you is, are the common Pheo symptoms only seen in hormone-secreting tumors? And what are those common symptoms of the non-secreting paragangliomas?
Very good question. So I'm going to answer. The symptoms that we describe, palpitations, headaches, sweats, are symptoms that are mainly in patients who have hormonally active tumors. So patients who do not have hormonally active tumors are not supposed to have those symptoms. Now, there may be patients who have tumors that are not hormonally active who may have, again, those symptoms, because in reality, the symptoms are not specific. When those symptoms happen, we have to look for other causes for those symptoms. So to give you an idea, if you have a head and neck paraganglioma, which is not hormonally active, and you complain of palpitations, we cannot assume that the palpitations are caused by the head and neck paraganglioma. We have to look for other causes of those palpitations in that particular case. So perhaps an evaluation by cardiology could be important. We have to see how the electrical system is. We may have to see if the patient has an arrhythmia that may not be related at all to the pheochromocytoma or to the paraganglioma whenever they are not hormonally active. In other words, we have to look for other causes. We should not make assumptions necessarily. We have to be careful in that regard.
Great, thank you for that answer. The next question comes as, are cardiovascular symptoms generally permanent after removal?
Very good question. The answer is no. They are supposed to disappear if they were related to the catecholamine excess because the catecholamine source has been removed. In other words, the palpitations are supposed to improve, the sweats are supposed to go away, the headaches are supposed to normalize, the blood pressure is supposed to get better. However, in patients who have been exposed to pheochromocytomas and paragangliomas for a long time, the high blood pressure, although may improve a lot, may still remain. In other words, after surgery, patients may remain with some degree of hypertension, but the hypertension may be easier to control, and the situation should not be overwhelming. So let's say that you remove a pheochromocytoma that is hormonally active and the symptoms of hormonal activity persist. What are the possibilities here? Number one, that the symptoms are not caused by the pheochromocytoma or the sympathetic paraganglioma, and we have to look for other causes. Or number two, that perhaps that pheochromocytoma or sympathetic paraganglioma that people felt that was a localized tumor is either metastatic. In other words, there are other tumors located in places that were not seen in radiographic studies before the surgery was done. To give you an example, I had one patient who had a metastatic pheochromocytoma years ago. The tumor that was identified radiographically speaking looked like a single tumor in the abdominal cavity. The patient continued with symptoms after surgery, and after surgery we did radiographic studies that included the skeletal part that was not evaluated in the previous radiographic studies, and that skeletal part demonstrated bone metastasis. Metastasis is the spread of the tumor to the skeleton. Or the other possibilities, for instance, when you have a multifocal tumor and you do just radiographic studies, for instance, in the abdomen and pelvis, you identify a single tumor, you think that that's the only cause of the abnormal hormonal activity, you remove it, the symptoms persist. Yes, you have to look for other tumors that may happen, in particular in the context of familiar or hereditary disease. So you may need to order radiographic studies, for instance, in the chest, looking for thoracic paragangliomas that may produce those hormones. So there are several possibilities that may explain the persistence of symptoms, some not related, others related to the syndrome.
Great, thank you. Next question is, can pheochromocytomas or paragangliomas cause long-term effects on fertility?
Very good question. The answer is no. No as tumors. So could women, for instance, with a pheochromocytoma or a sympathetic paraganglioma have abnormal menstrual cycles? The answer is yes, because they are sick. And many times the stress is such, hormonally speaking, that they may have what we call amenorrhea, or simply the menstrual cycles stop and they are not fertile for that particular time. But once the pheochromocytoma or the sympathetic paraganglioma is removed, is cured, the fertility is supposed to return. Now, in patients with metastatic pheochromocytomas and paragangliomas, many of them are fertile despite of the excessive hormonal activity, but we have to remember that the treatments that are provided to those patients may predispose to infertility. For instance, chemotherapy, especially in the long term, may damage the ovaries in women, may damage the testes in men. Radiopharmaceutical agents, yes, they are used usually in high doses, and yes, a potential side effect is, of course, infertility.
Sure, great, thank you. The next question, I'd like to elaborate on this question. Let me read it first. Which doctor or specialists are part of any patient's gastro team? And I would like to maybe expand upon that question, Dr. Jimenez. How does one assemble a patient care team, obviously depending upon the symptoms, but what doctors or specialists should anyone be concerned of assembling, and who's really in charge of that?
Very good question. Unlikely all of you, I know that many who are in the audience are patients. In reality, likely the experience that you have, most of you have become really the experts on pheochromocytomas and paragangliomas. And many times this is frustrating to many when you go and see different doctors. Yes, they don't have a lot of knowledge on this rare disease. And that's a real problem in clinical practice. So you start looking for the people who can help you. So to create a team of people who can help is something that, of course, will depend on experience, interest, passion, and many other aspects. And it's usually what you see in referral centers, where we have a lot of experience. So for instance, at MD Anderson, how is our team? So we have an endocrinologist. I am an endocrinologist by specialty. I have the title of being an oncological endocrinologist because the institution of the state of Texas gives me permission to prescribe systemic therapy for patients who have metastatic disease. But I work together with an oncologist who is able to prescribe IV chemotherapies, and he helps me whenever I have someone with metastases. Whenever I have someone with problems in the heart, what I mean by that, electrical problems, cardiovascular issues, I have a cardiologist that works with me. Although in general, I am in charge of the blood pressure management and the normalization of the symptoms that the patient has. I work with a nurse practitioner who is very well trained on this, so she helps me to control the blood pressure in our patients periodically. I work with two different types of surgeons. I have endocrine surgeons who are very good, as well as urologists. One of them are excellent groups to deal with the resection of the tumor. We have genetic counselor or whatever is related to genetic testing. We need to have an excellent service of nuclear medicine. It was not the purpose of this lecture, but yes, many times patients with pheochromocytoma and paraganglioma need nuclear medicine studies, so we need to have them. We need to have the expertise from nuclear medicine. Yes, excellent radiologists. And anybody else who wants to help is very welcome to that particular group. In other words, it's a multidisciplinary group, the one that we have for patients with pheochromocytomas and paragangliomas. Is this what we are going to see in real life? Well, for most part, no. So who could be the person who can help you to control the cardiovascular part? Well, theoretically, an endocrinologist could, but many times endocrinologists may need the assistance of a cardiologist if the experience is limited. Sometimes a cardiology can help, but yes, the cardiologist may need the assistance of an endocrinologist. In other words, these are specialties that sometimes are complementary.
Great answer. And, there are many of us in the community that may have a lot of great insight as well, those who've lived through this. So with that, I'd like to just kind of even tie in that we are currently creating, the PheoPara Alliance is creating a PheoPara Center program, which we'll be using to direct patients where to go to receive quality PheoPara treatment, such as Dr. Jimenez there at MD Anderson in Houston. More info on that will come in the fall on our website, pheopara.org. And I'd also say that the community groups, specifically on Facebook, are great places to ask questions or post concerns and really get an outpouring of support through people who've experienced it. Next question comes from a patient here, and the question reads, I had a non-secreting paraganglioma removed, and now I have many metastases in the bone. How do bone mets behave over time?
Very good question. When you look at the natural history of paragangliomas or pheochromocytomas, in general, they are quite heterogeneous tumors. So, although it was not part of the lecture, when you look at the survival rates, they are quite variable. There are patients who have tumors that are quite aggressive and they grow very fast. And there are patients who have tumors that behave very well over time and they experience minimal growth or simply no growth over decades. And there are patients who are in between the two extremes. I would say that based on clinical experience, most patients are in between the two extremes. The ones that I prefer to see, of course, are the patients who have disease that behaves really nice, with disease that doesn't change, doesn't grow, and that remains asymptomatic. Why? Because I don't have to do really much. I simply have to be sure that the patient is doing well. And to give you an example, I have one patient who was diagnosed with a pheochromocytoma that was metastatic in 1980. Yes, by then I was a child, so I was not the doctor at that particular time. The patient is from Myanmar, Burma, in Southeast Asia, and then he moved to the US, and the metastases in the skeletal tissue have been present for several years. And we have not needed to do anything for that patient, and he's now 89 years of age, and he feels wonderful, and he comes to see me every year, and I don't have really much to do. I simply be sure that he is fine. There are other patients in whom the disease is progressive, and yes, whenever we have evidence of progression, we may have to offer some type of systemic therapy. And there are some medications that could be quite effective. This is a rare condition. Unfortunately, we don't have a lot of the drugs that are effective, and there is only one medication that is currently FDA approved for the treatment of pheochromocytomas and paragangliomas that are metastatic. So to give you an idea, whatever we learned from the clinical trial with that drug is called high specific activity MIBG. It is a drug that was approved in clinical practice last year. And yes, we are using it currently in the clinical trial, and now in routine, we have several patients who have bone metastases, and whenever those tumors are MIBG positive, we've been able to provide them with MIBG, and so far, I think I've been lucky, and they've been lucky. Our experience is quite positive. In those patients, for instance, whenever they have tumor growth, the tumor became quite stable. And it seems that the symptoms have improved. And from the clinical trial, I can tell you, I have several patients who were having progressive disease before they participated in the clinical trial. And some of them are now 5, 6 years after initial treatment without any evidence of progression. But not all tumors are MIBG positive. So we have to look for other options. And yes, that's when we go for alternatives, several in clinical trials, such as Lutathera, or others that we may be able to do in clinical trials sort of label. And there are names such as cabozantinib, lenvatinib, and the same chemotherapy. But the point here is that everybody is different. So whenever you have a condition like that, yes, it is important to assess how rapid it grows, how stable it is, how the symptoms are, and based on that, we create a plan for assessment and follow-up and treatment, of course.
Great. You know, we do have several more questions that are unanswered, and I do not believe we will have time to get to all of them today. So I would like to encourage. Yeah.
If you need me, I have time.
Well, we can even go another minute or two here. But if we do not get to your question specifically asked, if we are unable to ask that on today's webinar, I would like to invite everyone or anyone to email info@pheopara.org, and we will get Dr. Jimenez to possibly answer some of those. So again, that email address is info@pheopara.org. You know, another question here, we have another question that I have a quick positive note to end with your input, Doc. But this next question is, what is the relationship between cyclical or episodic Cushing's and Pheo?
Oh, very interesting. There is pheochromocytomas and sympathetic paragangliomas may rarely predispose to what we call ectopic Cushing syndrome. What is that? It is a condition in which the tumor becomes crazy and decides to bother the particular individual who has it by producing a hormone that we call ACTH, or a precursor of it that we call CRH. And those are hormones that may lead to a Cushing syndrome. So yes, you may see occasionally, in reality it's quite rare, patients who have pheochromocytomas and sympathetic paragangliomas with Cushing syndrome. And yes, whenever the tumors produce the catecholamines, the manifestations of Cushing sometimes are exacerbated. But if you ask me in clinical practice, that's quite rare. There is another interesting condition that sometimes becomes a differential diagnosis of pheochromocytoma or a sympathetic paraganglioma, but it's not really pheochromocytoma or a sympathetic paraganglioma. And that's what we call the classical cyclical Cushing. And the cyclical Cushing, we mainly see it in the context of another abnormality that we call macronodular adrenal hyperplasia. What happens there, which is quite interesting, is that many times those adrenal glands have receptors, such as the beta receptors, located in the adrenal cortex. And those beta receptors are sensitive to the production of catecholamines whenever they are produced because of stress. And whenever they are produced because of that stress, symptoms of Cushing syndrome are developed. And that's why we call it classical Cushing syndrome. So it comes and goes depending on the stress. But that's a condition that is a differential of a pheochromocytoma or a paraganglioma. It's not a pheochromocytoma or paraganglioma, but the clinical manifestations may overlap, and that's why they can get also connected.
Great, thank you. Finally, I'd like to thank Progenics one more time for their educational series grant to make this webinar today possible. But I'd like to end, Dr. Jimenez, with end on a positive note. You had already mentioned some great news in the field of research and development with the newest release of the drugs that you are now seeing in use. You can add to that, or if you know anything else, enlighten us. But we would like to end on a positive note today. Tell us something exciting going on today in the world of PheoPara research.
Well, there are so many exciting things. I think we were able to recognize the genetic aspects of many, not all, but many. We're able to do a screening for pheochromocytomas and paragangliomas in individuals who are susceptible for them. And we're able to identify them early in life. So we're able to prevent aggressive presentations, which is really nice. We are learning more about the hormonal manifestations of the disease. And perhaps one of the areas that I'm really excited about is the area that perhaps we need the most is the one of therapeutic development for those patients who have what in the past we used to call malignant pheochromocytoma or paraganglioma, and now we use metastatic pheochromocytoma and paraganglioma. Those are patients who usually arrive with advanced disease, and I can tell you 10 years ago, the only treatment that we have in the US was only chemotherapy. And it was the old drugs, cyclophosphamide, vincristine, and dacarbazine. And yes, they may help some people, but they are tough. They are not easy to tolerate. And in reality, they are not able to cure patients. But they have an impact, a positive impact. Saying that, thanks to the recognition of how pheochromocytomas and paragangliomas are over the last decade, new drugs are, and now we hear names of different categories, different types. So what in the past was a single type of treatment, now we have a drug that is approved by the FDA, such as high specific activity MIBG, which is different from the old MIBG. There are no comparative studies in between the two. But as someone who have experience with both, yes, I believe that the new one is more effective because it's able to release a much higher level of radioactivity inside the tumors whenever the tumors are MIBG avid. Now, there are clinical trials with drugs like Lutathera. We have to wait and see what happens with those clinical trials, that there is something under evaluation. There are drugs like the tyrosine kinase inhibitors. Yes, they don't work forever, but at least for some time they may help. And they include drugs like cabozantinib, lenvatinib, sunitinib, pazopanib, and other names. I am excited also because there is now interest in a new drug that we call the hypoxia-inducible factor 2 alpha. This is not an FDA-approved drug for anything. It is a drug, however, that may target the core of the pheochromocytomas and the paragangliomas. It is a drug that has been evaluated for kidney cancer. And believe it or not, in patients with kidney cancer, there are some results that are absolutely impressive. Perhaps that's the same situation with pheochromocytomas and paragangliomas. Are these drugs able to cure? No. But the point is that we are learning more and more about them. And the way I see things is that later we may be able to combine them in an effective manner. And whatever that combination may be, may help us to finally conquer this particular disease. But I'm much more positive. Now, when I see patients who have progression, and for instance, the tumor is semi-big, as a clinician, I feel quite relieved. I say, I have something to give. And for most part, they do really fine.
That's great news.
That's important.
Yeah, great news. And Dr. Jimenez, I don't know if I could say thank you enough, but I really do appreciate your time today. And of course, your dedication to the patient community means a lot to me as one of your patients. You've left an indelible mark on my family, so thank you again for being here today to share your knowledge with everyone else. I would like to invite the entire community again, just a reminder, we do have 2 more patient education webinars this August. Links to those to register are at pheopara.org. You can also sign up for our e-news and follow us on social media by searching for pheopara. This webinar today will be made available on YouTube within the next several days and also on our website. We will also be transcribing the Q&A portion and we'll have that available as well. If this information has been useful to you and you're interested in donating, you can do so today at pheopara.org/donate. You can also buy some cool swag there, shirts or anything else that will let your immediate community know who you are and what you're battling today. Again, I'd like to thank everyone for attending. Without you, this community doesn't go a very long distance. So thank you for being here today. Get involved, and remember, we are stronger united. So thank you again, Doc. Thank you everyone for joining. Thank you, guys.
Thank you, everybody. It's wonderful to be here.
Thank you.